Hello and welcome. Today, we're diving into a condition affecting the urinary system, ureteropelvic junction obstruction, often shortened to UPJ obstruction. This mouthful of a name describes a blockage where the ureter, the tube carrying urine from the kidney, joins the renal pelvis, the funnel-shaped collecting system within the kidney itself. We'll explore what causes this obstruction, how it affects the body, and the options available for diagnosis and treatment.
So, let's get started.
What causes this blockage in the first place? In most cases, UPJ obstruction is a congenital condition, meaning it's present at birth. The exact cause is often unknown, but several factors can contribute. These include abnormal muscle development in the ureter wall at the junction with the renal pelvis, the presence of extra tissue that compresses the ureter, or abnormal kinking or twisting of the ureter itself. Less commonly, UPJ obstruction can be acquired later in life due to scarring from prior infections, kidney stones, or even injuries. Let's break down what happens when the UPJ is obstructed. The kidney continuously filters blood and produces urine. When the flow of urine is blocked at the UPJ, it backs up into the renal pelvis, causing it to swell. This swelling is called hydronephrosis. The increased pressure can damage the delicate tissues of the kidney over time, potentially impairing its ability to function properly. If left untreated, chronic hydronephrosis can lead to permanent kidney damage and even kidney failure. UPJ obstruction affects individuals of all ages from newborns to adults. It is estimated to occur in about 1 in 1,500 live births, making it a relatively common congenital condition. While it can occur on either side, it tends to affect the left kidney slightly more often than the right. Some studies suggest a slight male predominance, but the overall incidence is relatively equal between genders. The symptoms of UPJ obstruction can vary depending on the severity of the blockage and the age of the individual. In infants, it might be detected prenatally during a routine ultrasound, revealing hydronephrosis. Older children and adults may experience intermittent flank pain, often described as a dull or sharp pain in the side, particularly after drinking large amounts of fluids. Other symptoms can include nausea, vomiting, urinary tract infections, and the presence of blood in the urine, known as hematuria. In some cases, UPJ obstruction may remain asymptomatic for years and only be discovered incidentally during imaging for another reason. Diagnosing UPJ obstruction involves a combination of imaging techniques. Ultrasound is often the first step, as it's non-invasive and can readily detect hydronephrosis. If ultrasound suggests a UPJ obstruction, further testing is usually performed. A diuretic renogram, such as a MEG3 scan or DTPA scan, uses a radioactive tracer to assess kidney function and urine drainage. This helps determine the severity of the obstruction. Other imaging modalities like CT scans or MRIs can provide detailed anatomical information and rule out other possible causes of hydronephrosis. A VCUG or voiding cystoarthrogram may be performed, particularly in children, to rule out vesicoreteral reflux, where urine flows backwards from the bladder into the kidneys. While UPJ obstruction isn't typically classified into distinct types, it can be described based on the severity of the obstruction. Mild obstruction may cause minimal hydronephrosis and little to no symptoms. Moderate obstruction involves more significant hydronephrosis and may cause intermittent pain or urinary infections. Severe obstruction causes significant hydronephrosis, impairs kidney function, and leads to more frequent and severe symptoms. The severity of the obstruction guides the treatment approach. The treatment for UPJ obstruction depends on the severity of the condition and the presence of symptoms. In mild cases, particularly those detected prenatally, observation with serial ultrasounds may be sufficient. If the obstruction is causing significant symptoms or affecting kidney function, surgical intervention is typically recommended. The gold standard treatment is pyeloplasty, a surgical procedure to remove the obstructed portion of the ureter and reconnect the healthy ends to create a wider, more patent passage. Pyeloplasty can be performed using open surgery, laparoscopically, or robotically, with robotic surgery often offering advantages in terms of precision and recovery time. In some cases, a temporary stent may be placed in the ureter after surgery to ensure proper drainage and healing. In rare instances, if the kidney function is severely compromised, nephrectomy or removal of the kidney may be necessary. Unfortunately, there's no known way to prevent congenital UPJ obstruction, as it often arises during fetal development. However, early detection through prenatal ultrasound can allow for timely diagnosis and management, preventing long-term kidney damage. Individuals with a history of kidney stones or urinary tract infections can reduce their risk of acquired UPJ obstruction by maintaining adequate hydration and seeking prompt treatment for these conditions. The prognosis for UPJ obstruction is generally excellent, especially when treated promptly. Pyeloplasty has a high success rate, with most patients experiencing significant improvement in symptoms and kidney function. Recent advances in minimally invasive surgical techniques, such as robotic pyeloplasty, have further improved outcomes and reduced recovery times. Research continues to focus on understanding the underlying genetic and developmental factors that contribute to UPJ obstruction, with the hope of identifying potential targets for future prevention strategies. Furthermore, ongoing studies are evaluating the long-term outcomes of different treatment approaches and refining surgical techniques to optimize patient care. So, with early detection and appropriate management, individuals with UPJ obstruction can look forward to a healthy and fulfilling life.